Perfect. Thank you very much. It's certainly an honor. As I read through Dr. Towery's biography, it certainly resonated with me. Being a Kentucky boy, I spent time in the Army, and I'm just a clinician. I see patients. That's what I do for fun, and I just happen to write about it. And that basically has been my entire career. So I happen to write pretty well, and I like stats. But at my day, these days, we're all being asked to see more and more patients. That's not exactly a punishment for me. That's what I enjoy doing. So what I thought we'd do this morning is, knowing not everybody does thyroid cancer, I'm going to show you the journey that we've been in thyroid cancer over the last sort of 15 or 20 years, and some of the challenges that we've run into trying to de-escalate care, which is the opposite of what we typically do. Now, apparently, if your job is to de-escalate care, nobody's going to give you money to do that. So pharma companies, I have no conflicts. There's nothing about doing less. But I think it is important. It's important to know the bias of the presenter. The thyroid community knows me very well. I'm a minimalist. I want to do the least that we can. I think less is better most of the time. I worry that all of our excessive diagnosis and treatments may actually be doing more harm than good. And so the philosophy in thyroid cancer, until about 10 years ago, or still in many places, we do everything unless you're an exception, then we might do less. I would like to look at that glass exactly flipped opposite. We're going to do just enough, and we're only going to do more if you earn it. They used to say, let the punishment fit the crime, right? So the idea is, I don't sentence you to life and then let you back off if everything is good. No, we'll do just what we need to do. So what we'll do is we'll start with a couple cases. The first case will happen to be you, because everybody always says, well, if you were my brother, if you were my sister, if you were my cousin, you get that, right? Well, what would you do? I've been quizzing the world. Nobody has ever asked me, if I was your mother-in-law, what would you do? Never. That has never come up. I'm waiting till it happens, and it will, because patients watch these on videos. I'm going to show you a little bit about how we treat thyroid cancer, just at the 30,000-foot view, then look at how we've de-escalated. And then really ask this really critical question: is all these great outcomes we're having because we've got very effective treatment and surveillance, or is this just the natural history of the disease that we're taking credit for? And while I'm going to talk about it in the context of thyroid cancer, you can envision situations in your scenario, whether we're talking about diabetes or renal failure, other malignancies, lots of stuff that we ask. We've added lots of stuff on the last 10 or 15 years. How much good have we done by doing that? So here's you. Imagine with me, the way this usually works out is, if you're a doctor, you find out you have a thyroid nodule, and about 10 minutes later, you've talked a pathologist into doing a biopsy. These typically, the results at Memorial, for some reason, come in Friday nights at 4:30. I don't know why. So you get a quick call from me on 4:30 that says, look, I know we accidentally found this thyroid nodule because you had a carotid ultrasound, or you had a CT, you had some other reason. In New York, these patients go directly to the biopsy centers. There are pathologists and radiologists that are just waiting with a needle in their hand for you to walk into the door and biopsy things. So haven't seen a surgeon, no endocrinologist. This gets biopsied. It's a 4-millimeter thyroid nodule, very suspicious looking with all those microcalcifications, and the biopsy shows definite papillary cancer. And if I had you vote right now, what would you say? Some people would say, get this out of my body. I want surgery. Other people would say, do I really have to have a surgery? I've heard about all this overdiagnosis. Is this one that we could watch? And other people say, I need some more information. Now, I'll tell you, about half of the audience has already decided you want a thyroid surgery. You can't admit it because you know I'm a minimalist. But about half of this audience has already said, nice talk. When can you schedule that? And we're going to talk about why that is. How did we get there? Now, the second case is sort of a prototypical low-risk patient. This is more typical because we're all different. I'm older than most of you guys. Some people are my age. Some people are married or single or going to get pregnant, or they're going to do all different reasons they may choose surgery versus watching. So let's pick one that we can all agree to. And this is a very typical 29-year-old female. The GYN doctor feels a nodule. Very common. GYN doctors are good at feeling next. And they found this nodule, and sure enough, it's a papillary thyroid cancer. And so now she wants to know, what do we need to do? So if this is your daughter, your sister, your cousin, your neighbor, what's the stuff you need to know as a not thyroid cancer doctor to be able to give that advice, right? Because we all get those phone calls. That people, it's amazing. They call the house and they want to ask me about thyroid cancer. My wife says I'm traveling in Louisville. That's fine. They go ahead and ask the questions to my wife, who's a radiation technologist, right? They just want to talk to somebody. So what do you need to know? Well, you need to know thyroid cancer is pretty uncommon. So we're about 2% of all cancers. You put it into real numbers, about 40,000 cases a year, compared with breast cancer or prostate, they're like 300,000. So a little uncommon tumor. We're not surprised she was diagnosed because this is the risk of being diagnosed prevalence over the last 20 years. And you can see in the 1990s, we started getting this huge increase that we think is probably over detection. The bottom is the mortality rate, which is almost none, hasn't changed. So we're finding all these, and when you look at them, these are all really small thyroid cancers. That's what we're finding. And Keith Heller, a surgeon in New York, gave a lecture at our place one time, and he said, we've moved from the age of palpation to the age of detection. For the fellows and residents that are watching online, you may not recognize this, but that age of palpation, that's something called a physical exam. Okay, imagine with me, you can't get the ultrasound machine to turn on, or in New York, we have blackouts. So there is a situation where you could actually use your hands. And in fact, we were talking before, we feel next from behind. That's how we teach to do it. And in the age of palpation, guess what the survival rate was in thyroid cancer? 99%. We didn't change it. But the age of detection has come on. And what has happened is we have found out there's this huge bunch of thyroid cancer below the radar screen. If you look in autopsy studies and you look in surgeries that are taken out for other reasons, 10% of the US population has thyroid cancer. 10%. That's the same number of people who have diabetes. Can you imagine? We're only diagnosing 40,000 cases a year. But if you take your ultrasound out to the mall in Florence and ultrasound everybody coming through that door, you're going to find to start the other 26 million. So the age of detection has got to have found disease that doesn't matter, right? Because otherwise you couldn't have these numbers. Then the trick is, how do we figure out which ones? Now, survival in thyroid cancer is seldom an issue. If you look at 5-year survivals, this is the same at 10 and 20 years, 99%. In fact, in our 29-year-old, it's even better. The likelihood of dying is only 0.7%. And because I gave her a small one inside the thyroid, her survival is 99.9%. In fact, if she had to come back to New York every 6 months for 2 years, and then once a year for 10 years, the risk of her dying in a car accident is more than the risk of her dying from thyroid cancer. So if I demand intense follow-up, I may cause worse overall survival than if she never comes back to New York. Does that kind of hurt our heads? I wish that was a joke. It's not. That's the reality, right? So when we're dealing with these low-risk mortalities, we really have to look and see what we're doing. So what had happened, if we go back to basically mid-1970s, the current paradigm is the one-size-fits-all. We do a thyroid surgery, usually taking out the entire thyroid. We'll take out any involved lymph nodes that are visible. And then about 15 years ago, we started saying, well, what if there's some microscopic lymph nodes? Let's take out some more lymph nodes. And the more surgery you do, the more complications you have, because those are recurrent laryngeal nerves running behind the thyroid that go to the voice box for make your vocal cords work. Parathyroids are in there. And then in the 1950s, we started using radioactive iodine. I love oncologists. When oncologists found targeted therapy, what, in the 1990s or 2000, awesome, welcome to the game. We've had targeted therapy since 1948. It's called radioactive iodine. Most thyroid cancers grab onto iodine. They have a pump on the outside. T3 and T4, 3 and 4 is iodine. So there's a mechanism for them to grab on and destroy them. Since I was in the Army, I call this my heat-seeking missile. You swallow it, it goes to the thyroid cancer. So in the 40s, we treated distant mets. In the 60s and 70s, we treated small volume microscopic stuff. And then because we've never seen something we couldn't overuse, by the 70s, we started using an adjuvant therapy. I don't know if you've got any leftover cancer, but let's just do a dose radioactive iodine to clean up the dust in the corners, right? That's adjuvant radioactive iodine. Now, we also have a growth factor, TSH. No endocrine talk can be done without some feedback loops that nobody understands except the old endocrinologists, but we have to put them in every talk. TSH is very cleverly called thyroid stimulating hormone. And if you might have thyroid cancer around, guess what you don't want a lot of in your bloodstream? Thyroid stimulating hormone. So we put them on some thyroid hormone pills to push the TSH down. And then last, we have wonderful surveillance. Thyroid globulins are blood test markers. It's only made one place in your body. And so if your thyroid is gone and radioactive iodine has cleaned up the dust in the corner, that thyroid globulin should be nice and low. So we got a great mechanism to tell, are you cured? And do we have a recurrence? And we've already talked about over-detection, because now apparently I can't cure anybody anymore, because the ultrasound can find an atypical suspicious lymph node in everybody. Thyroid globulins, we can now read down to 0.1. It's hard to get that less than 0.1, right? So we're in that situation. So if you look at where we were from 1975, which is the Mazaferi days of radioactive iodine, up until the guidelines we wrote in 2006, this is the one-size-fits-all approach. Most of the time in the 1990s, when I was a fellow, we were feeling things with our hands. The last 5 thyroid cancer patients you saw, how was their disease detected? Ultrasound, CT. When's the last one that walked in the door and said, hey, I've got this big mass? That's not anaplastic or lymphoma, right? Those exist, but that's not what we're seeing now. All of these guys got total thyroidectomies. We clean out the neck. We give them radioactive iodine. We make the TSH all the way down to 0.1. It was really easy clinic. I would be done with the thyroid cancer lecture now, and you could be a thyroid cancer endocrinologist, because that was all there was to it. Shared decision-making, I wrote sort of. Because shared decision-making in 2006, I made a decision and shared that with you. Here's what I think you should do. And I would explain why I was right. And this is what you should do. Can I have an amen? Yeah, that's what we did. And we called that shared decision-making. In 2015, the landscape had changed. Now we're in the age of detection, right? Now that same paradigm that Mazaferi taught me that works in big tumors and big lymph node metastasis and that bigger palpation age that I still do today, now we're starting to say, does that apply to all these little small tumors? And now we're starting to say, well, maybe we just take out half of the thyroid instead of the whole thyroid. Maybe you don't need radioactive iodine. Maybe the TSH doesn't need to. We're sort of entering risk adapted, right? We're recognizing these are a little bit smaller. Decision-making, now you actually have to talk to somebody about what are the lobe or half, right? Lobe or total thyroidectomy and the complications of each one. It's pros and cons. I mean, this becomes a more difficult decision. And by 2014, now what I'm seeing a lot is around New York, people are getting whole body MRIs to screen for cancer. This is wonderful for the universities, because now we're chasing false positives in the adrenal and in the pituitary and in the thyroid and in the lungs. It's a great money-making system. It's terrible for the patients, because now we're in the situation we have to prove something is not cancer. They got that scan to find cancer. We do a really good job proving what is cancer. It's a little harder to prove what's not cancer, right? And these guys end up with a bunch of that. We've now said, well, not only do you not need a total thyroidectomy, not only do you not need a lobectomy, maybe you don't need surgery at all. Holy cow, this is in my lifetime. This is like since the time I've been at Memorial. You don't need neck dissections anymore. We're definitely not going to use radioactive iodine. We're going to let the TSH come up a little bit. And now we're in a very individualized, very risk adapted, very shared decision-making. Shared decision-making for the fellow means your clinic is twice as long. I know it's good, but shared decision-making, they're going to ask questions you're going to have to answer. And they're going to ask questions you can't answer. So you're going to have to dodge those. That takes another 5 minutes. And welcome to clinical care. Now, I was really interested in, because I've been part of writing these guidelines since 2006, 2009, 2015. I write most of the chapters and up to date on thyroid cancer. Why is it that we made this change? And this is 20 years. I've been doing this for 30 years. This is 20 years of changing. And I ran into this information from Dr. Prasad in the group. And they did some interesting studies. This has been followed up several times. This is some of their original work. And they said, why did we abandon practices that we thought were good? Why did we change our mind? Now, I wish I could tell you it was like tons of randomized prospective trials. They looked at 140 different studies in the New England Journal. It's New England Journal, so they have to be right? That's gold. It's the Bible. There we go. Not newer or better technologies, but rather the new study that said, just kidding. What we've been telling you for 10 years, it wasn't right. Now, we've been telling you to do that for 10 years, and we've been really convinced it was right, but JK, just kidding. And so why was it? There was a couple of themes that came through. That very often, whatever we were deciding wasn't right, it was adopted based on very little evidence. If you look at the data that had us using radioactive iodine for adjuvant therapy, 300 patients, one center followed for 10 years. And we all adapted it. Why did we adapt it? It's the second pace. There's a mechanistic explanation. Radioactive iodine should work in thyroid cancer. It has to, right? These tumors grab onto radioactive iodine. More surgery has to be better. because we know there's thyroid cancer on both sides of the thyroid. We know there's small lymph nodes in the neck. More surgery has to be better. Radioactive iodine has to be better. And when we started finding minimal residual disease, the age of detection had to get better outcomes, right? Because everybody knows the sooner you treat cancer, the better off you are. And so you could see why escalation just happened, right? The TGs of 0.1 and high resolution ultrasounds and PET scans were not developed because we had a need. We had 99% survival on thyroid cancer. There was not a need there. It was the technology that got ahead of us. And we didn't stop to ask questions that say, does it make any difference if we're doing all that? And in fact, now for the thyroid geeks in the community, there are several areas we have to be careful with. You know, I'm a huge champion of active surveillance. We started it in the United States. The data is getting better on that, but we don't have 20 and 30-year follow-up data. And I'm just hoping in 10 years, somebody doesn't come back and go, remember what Tuttle told you? Just kidding. It wasn't good enough data. We should be, well, we have to be open to that, right? Things like remote access surgical procedures. We talked about, we can use targeted therapy to make radioactive iodine work better, or targeted therapy to shrink things before surgery, truly neoadjuvant in some of these big things. So all of those, we have to be aware the data is not huge, but yet we see all of our colleagues kind of moving in that direction because escalation is really easy, but we have to be aware to say, look, maybe something changes. And then when I look at why we changed some of the guidelines, I realized I was thinking about this wrong. If you write guidelines, everybody goes, can you just be more specific? Just stop waffling. Just tell us what to do. If it's this, do this, right? And then, of course, when we do that, you guys all go, you're killing us. You don't give us any options. So you can't win on this thing. But I'd thought for many years, I was just trying to get you the right answer. And if you did more or less than that, I would use pejorative terms like overtreatment and undertreatment. You're an overtreater. I often, when I give the lecture on minimalistic management, I start by saying, hi, my name is Mike. I was an overtreater. That's where I started, and I've overcome that. But now I sort of think about this as we're looking at a range of options that maybe, in fact, it's not overtreatment and undertreatment. There's a minimalistic approach and a maximalistic approach. And so maybe for my 29-year-old female cousin, maybe she truly does have 3 right answers. There's not a right and a wrong here. If I paint a scenario for her based on her life and where she is and her preferences and values. And in fact, back in October, I had to retake the endocrine exams. And as a chief of endocrine, I have to say that is really good for old people to do it. As an old people, I say that sucked, okay? Because I've done nothing but thyroid cancer. And I had to go back and learn all this stuff. And it turns out we're not the only ones waffling. Because what you're going to treat with diabetes, what do you have to look at? Do they have heart problems? Do they have kidney problems, right? It's not one size fits all. Same thing, obesity, hyperparathyroidism, lipids, right? And it's not that we've become more waffly. It's that there's a range of options. And it matters how people think about this. And we really got into this in this active surveillance group, where were these less than 1 centimeter papillary thyroid cancers that some colleagues in Japan, Akira Miyauchi and Professor Ito, for 20 years had been not doing surgery on these patients. Now, Dr. Akira, he works at a private hospital called Kuma Hospital. He's the president of the hospital. There's about 15 surgeons in the hospital and 1 endocrinologist. So guess what happens when they vote? Should we do surgery or should we do? He had total control over that and began to offer people the option of watching instead of immediate surgery with these small thyroid cancers. And it turns out about half the people said, cool, I'll watch. And the other half said, nice chat, get this out of my neck. And it's that 50% over and over. And so I had the opportunity to go over there and spend a few days with him and learn how to do this. And he's been a phenomenal mentor for me for the last 15 years. And I realized when I was there, he was really good at picking the right patients. The reason his outcomes were so good with watching was he was risk stratifying. There were certain people he'd just go, nope, yeah, you're not a good person to do this. And it wasn't always about the tumor. And we realized with JP Brito, who's now a thyroid cancer doc at the Mayo, he was my thyroid cancer fellow. JP was with me. JP's expertise is decision tools. And so he was thinking through this through the lens of what were the pieces of information we were using to make decisions for the patients and helping them decide, do you want to watch or do you want to do surgery? And it fell out into these 3 groups. There were certain characteristics of the tumor, certain size, certain location. If it's near something important that's going to grow into, we don't want to watch, right? If they've got lymph node metastasis, we don't want to watch. So there was that. And then there was the medical team characteristics. How good or how bad was your surgeon? If you're being operated on here, not a problem. You've got the lowest recurrence rates on the planet. If you're operating where I grew up, not so much. There's a reason they drive over to University of Cincinnati and have their surgeries, right? I get to lecture in all parts of the world. And if you have a surgeon that the complication rate is higher, then that make you lean toward watching, right? If you had an ultrasonographer group that's really good, you may watch some more, right? So those medical team characteristics make a difference. And then the last that I found most fascinating was the patient characteristics. What was different about these patients? Why did these patients want to watch? Because I remember early on in the days that these consults would be 4 or 5 people sitting there, small papillary cancer. You know how it is when you feel like the visit's coming to an end and you feel like you've got some resolution, and I would say, okay, it feels like we've made a decision here. And everybody shook their head. And this half of the room said surgery, and this half of the room said see you in 6 months. And they were all listening to me. I was answering their questions the same way. And what we realized, we needed a way to be able to figure out whether these guys were ideal, appropriate, or inappropriate for minimalistic management, for watching, right? And so this is my checklist. We look at the tumor characteristics in the patient. I was telling that story at Harvard probably 10 years ago when I was giving grand rounds up there. Pam Hartzband is an endocrinologist at Harvard. And Pam and her husband have written this book and now lectured many times. For the young people, that thing on the left is a book. It comes with pages and ink. I know you probably haven't seen one. It's okay. You can get this on YouTube as well, if you're still using YouTube or whatever fancy thing you're using. And so Pam had described how people make medical decisions. So you've already heard me use the term maximalist and minimalist. She talked about naturalist and technology. I realized that many of the patients I was watching, they weren't observing, they were treating themselves. They just rejected my treatments. They would do every herb I've never heard of, every over-the-counter product, exercise, I'm not familiar with that. They do lots and lots of things. Because I would come in the room and say, good news, everything is stable. And they would look disappointed. Wait, why are you disappointed? This is cancer. Stable is good. No. They had spent 6 months trying to shrink this puppy. So I had to get rid of that judgment. Now I just walk in the room and go, ultrasound is stable. Any questions? See you in 6 months, because I got a busy clinic. So it also became apparent to us that it wasn't just the doctors or the patients that had a bias, it was us. You've probably already figured out, I'm a minimalist, I'm a naturalist, and I'm a doubter. I see every complication in New York City from the surgery, because surgeons send me their patients because I normalize the complications, right? I hang out with surgeons too much. So if somebody asks me, have you ever seen a nerve taken out? Well, sure, today, no big deal. We see this happening, so I get to see them. And so when you look at my patients, we now have about 700 patients we're watching with no treatment at all, just small observation, and it's no surprise. The ones that want surgery, they're maximalists. They say, nice chat, glad I explored the option with you, get this out of my neck. They trust the technology. They're a believer that they're seeing the surgeon. That surgeon's going to do the best thing. And then the very next patient, or frequently the husband or wife of the patient, is the opposite. And the ones that choose active surveillance, they're like me. They're minimalists. I'll do surgery, but you got to give me a good reason. Let me try to treat this myself. You see this in diabetes, right? The diabetes, swear to God, doc, I'm going to lose some weight. Don't start me on the metformin. You see this in the lipid folks, right? The maximalists, as soon as their LDL gets 1 point above it, they're jumping on statins, right? And the minimalists are like, all right, doc, I swear, I know I've been telling you for 6 years, I'm going to get on my diet. I'm going to tell my wife about it. We're going to be on board, right? That they're telling you that's where they are. And the doubters are worried about complications. And so what that meant is for any individual patient, without me understanding their values and their system, I can't tell them what to do. And so when patients ask me, they always do, well, if this was you, what would you do? I always have to say, well, you need to know a little bit about me. I'm a minimalist. And now, fortunately, my wife is a maximalist. So it allows me to go, if it was me, I would probably watch that. But I can tell you, if you were my wife would probably choose different than me, right? Same data, same information, and then help them try to make that decision. Now, Louise Davies is the doctor that 15 years ago first showed that rise in thyroid cancer. So Louise has been interested in this. She's up at Dartmouth and at the VA up there. And in a paper that we wrote with the Japanese guys, we were trying to figure out, how do we do this shared decision-making? How do we explain that sort of patient preference and that sort of stuff? And Louise, because this is actually a hiking trail that leaves the parking lot at Dartmouth University. They hike a lot, right? So when your parking lot is the beginning of a trail up a mountain, that says they hike a lot. And so Louise envisioned this as we're the guide. When we do looking for tours in other cities and other parts, you get a guide, right? You expect that guide to know some information. We should advocate for what we think is the best pathway. There were probably parts of the city you didn't want me visiting last night. And you'd have probably very nicely shared with me, I know you used to go there in 1990, Michael, probably not a good time now. Or come look at this new place, right? Lulu, where we went by. That was an old factory place when I was here. I'm like, we're going there? It was gorgeous, right? But the tour guides knew that. The patient understands there's options. Maybe I want to cross a bridge. Maybe I want to climb a mountain. Maybe I want to walk on blacktop, right? I need to know that. And we walk this journey together. We're going to do it. And my patients will often say, this is what we talked about, or when this grew, we knew this would happen, right? So I sort of think about it as that tour guide mentality. Now, when I look and sort of think back, what was it that allowed me to go from being a really overtreater? Because I trained in the Army under Wartowski and Berman and Ernie Mazzaferri. That was the age of palpation, to be fair, right? Those were big tumors where I was training. And we were taught one size fits all. Total thyroidectomy, radioactive iodine, we are going to cure this disease. And then in 1999, I moved to Memorial. Unbeknownst to me, Memorial is the home of minimalistic management. Surgeons all know that, right? That's the Mayo Clinic in Memorial, the home of lobectomies, and the home of being less aggressive in the 90s and the 2000s. The first thing that happened is I ended up with a pure thyroid cancer clinic and started seeing between 60 and 70 thyroid cancer patients a week. That was my entire practice. I don't know anything about diabetes. You know, the fellows would roast the attendings. Now, this isn't in the good old days. You guys can't do this anymore, apparently. But in the good old days, they used to have a party at the end and roasted the attending. And they found one of my thyroid cancer consults notes that under medicine, I just listed the words diabetes meds. I didn't put which ones. Just as an endocrinologist, I should be ashamed of that. And I was like, dude, I got a great clinic. So I got to see lots of folks. And the other thing that happened was I started doing follow-up on patients treated by our surgeons. And I ran into this guy. Ashok Shah has been my thyroid surgeon for almost 25 years now. And Ashok's a wonderful Indian guy, very trusting, very soft-spoken. You just trust him. He's just very wise. He knows what he's doing. And he would say things like, trust me, she's going to do fine. I'll follow her with you. The trouble was, this was 2001, and he was trying to get me to follow a lobectomy for a 5-centimeter follicular thyroid cancer. Now, you might be talked into that today, but can you imagine how that hurt my heart? And what's worse, she was a nurse, a junior nurse at Memorial. I knew she was going to be with me for 20 years. And I'm still seeing her today. And I'm still amazed every time I see her that she's doing fine. But Ashok also sent me patients that he'd operated on 5 or 10 years before in a very minimalistic management. Lots of lymph nodes, no radioactive iodine. Big tumor, only did a lobectomy. And those patients were doing great. And they were doing great with my minimalistic detection. I said, look, dude, I'm going to find all your recurrences because I'm going to do ultrasounds. I'm going to do thyroid. And after a couple of years, I realized I wouldn't find anything. Now that hurts your head if you're an overtreater, because I thought the reason those patients were doing great was because of my treatments. And now slowly, because I'm not all that smart, over a few years, you begin to go, holy cow, is this the treatment or is it the natural history of the disease? And you guys will get this because around the world, nobody else understands that roosters crow in the morning on the farm before the sun comes up. So maybe I was the rooster and the sun was coming up anyway. Maybe these patients are going to do great and my therapies weren't doing anything about it. That's a hard thing to admit, right? Because I look at my papers in the 90s. I was writing about, I did this and patients did great, assuming it was a therapy. But maybe I was caught into this trap that says one size fits all. I overestimated the benefits, right? That they would have done terrible if I wouldn't have done something. So I find more minimal disease. I overestimate the risk of harm from that minimal disease. And now I'm in a trap. You need more outcomes, right? So this circle that we fell into. The other thing that happens when you start seeing lots of thyroid cancer patients, knocking out 60, 70, 80 patients a week, those 3 or 4% side effects that seem pretty uncommon, you're now seeing every week, 3 or 4 times. They are not so uncommon anymore in a high volume center. And really appreciating how bad vocal cord dysfunction was. It wasn't just they got hoarse, they aspirated. because you need those vocal cords to come together so that food doesn't go down the wrong pathway. Hypoparathyroidism, I've come to loathe. I hate hypoparathyroidism. I think it's one of the most difficult things to treat. I've been doing it for 30 years. And patients just struggle with it time and time again. Radioactive iodine, not just dry mouth, their teeth fall out in 10 years, literally fall out because they have a permanent dry mouth. And without that saliva, they lose those teeth. Secondary malignancies. I don't see this very often, but last week, one of my patients I treated 10 years ago for metastatic struma ovariae, with just 2 doses of radioactive iodine, was diagnosed with AML. And so Friday night, I had to call her and say, we got the bone marrow biopsy, you got AML. She'd been in remission for 9 years, but there's very little doubt that it was the radioactive iodine that I gave her all those years ago. That changes what you do when you start seeing low-risk patients. It's no longer theoretical. And then the TSH suppression. One of my junior faculty wrote a paper that showed that the people I was doing all this heavy-duty suppression in my first years, while I was not decreasing their recurrence rate, I was increasing the rate of AFib and osteoporosis. Don't recommend that if you're a junior faculty to write a paper with your senior faculty showing that he was hurting people more than he helped. But Dr. Bukai was kind of brave. She trained under Marty Sirk. She didn't know any better. And so that was a paper that we wrote with Laura and really made us, it made perfect sense at that point. Now, the other thing that began to go on was we began to have the opportunity to watch patients that we wouldn't have normally watched. It made sense to watch the little ones. But in my first few years at Memorial, we get to see lots of people that have bad cancers. Leukemia, stage 4 lung cancer, stage 4 colon cancer. And yeah, they had a thyroid cancer. And we never treat that thyroid cancer, treat the life-threatening disease. Now, sometimes that's 2-centimeter thyroid cancers, 3 centimeters. Sometimes that's thyroid cancer with lymph node metastasis that we would watch for a year or two till we got them through their initial therapy and make sure everything was okay. And we very seldom saw those grow. They didn't get out of control. They weren't competing with the other tumor. And so it began to give us this feel that maybe the natural history was much less aggressive than I thought. And this is Jayton Shaw. Jayton was the chief of head and neck surgery for many years. And I'd been at Memorial for probably 6 months when after one of the meetings, we were talking about how to treat. Remember, I'm still an over-treater at that point. And Jayton, in his usual very bright, condescending way, said, Michael, once you understand the natural history of thyroid cancer, then everything becomes easy. If you understand the natural history, and Jayton understood the natural history. And so that started in 1999, my entire journey on risk stratification. And if you think about everything that we've written about AJCC and ATA risk and observation, it came out of this. This was hard for me. I love this quote attributed to Mark Twain. He probably didn't really say it, but everybody gives it. It ain't what you don't know that gets you in trouble. It's what you know for sure that just ain't so. I knew those treatments that I was giving and doing it very well was giving us the great outcomes, and it turns out it wasn't true. So if I look at what the natural history of thyroid cancer is now, you get some initiating oncogenic event, and we don't really know what that is in most of the adults. You get some growth over years and years to find some when it's at diagnosis, right? It gets stumbled on by an ultrasound or CT scan. And if you look at that point in time, what does it look like? These are generally 40 to 60-year-old. I now refer to this as middle age as I've aged out of this. So 40 to 60-year-old folks. The primary tumor, about 7 millimeters. It's 7 millimeters when you're 40. It's 7 millimeters when you're 50. It's 7 millimeters when you're 60. It's not growing through that age. It's multifocal. Now, and we've all said we're fine with lobectomy, but in fact, 18% of the time there's thyroid cancer on the other side. We don't see an 18% recurrence rate. It's cancer. There's microscopic extrathyroid extension a third of the time. And there's lymph node metastasis over half of the time. Now, this hurts your head because our treatments have been lobectomy or observation, which must mean that many of these small lymph nodes are not changing. And we're starting to get this picture that maybe small thyroid cancers metastasize the lymph nodes, and the majority of them don't change. That's how you get 10% rate in the background population that we don't know about. Now, that's bizarre, right? If I told you that you're going to get metastasis to lymph node and then everything is going to chill, you'd say, you got to be out of your mind. A.L. Robenshock, one of my previous fellows, looked back at autopsy studies. He looked at the other way and said, looked at 29 different studies, 740 patients that died without a history of thyroid cancer, right? They didn't have, this is subclinical disease. There's the same 10%, 8.5% had thyroid cancer. There's the same 60-year-old age group, about the same size, 4 or 5 millimeters. multifocal. There's the lymph node metastasis, 11%, because it's only big visible lymph nodes, right? So this idea that these people died from something else with this subclinical disease is real. So the first concept is that the natural history of thyroid cancer is not continued rapid growth. That just doesn't happen. It's early metastasis, and then those metastases often stay the same. But then the other group is what happens, how do we know if they're going to do that? So this is one of the studies that we've done. This is the first, 500 patients or so that we follow with observation and ask what happened to these guys. And you can see the blue line going, blue dots going all the way across, 78%, they haven't changed in 5 or 10 years. Papillary microcarcinomas, biopsy proven, they're not changing. The yellow ones, a few of them are changing. They were changing before they met me. I just didn't know. And then over the first 2 years, you could tell they were gradually getting bigger. And then the green line is ones that were growing more slowly. I couldn't tell the first couple years, but if you watch for long enough, you can tell they're slowly growing. And just like the Japanese had taught us, if we wait, that's relatively quiescent disease, treat at the time of progression, we still have 100% survival, no distant mets, everybody does fine. So now instead of treating 100 people, we've treated 20 people instead of that. It was interesting, and I still don't understand this, is during this period of observation, which is the white thing, whether the natural history is these thyroid cancers have grown up to 7 or 8 millimeters and get stuck there. Kind of the Judah Volkmann, they can't get past a centimeter without vascularity and angiogenesis, or in fact, whether these are just growing really slowly. Because if things are growing really slowly, I can't tell over 5 or 10 years, right? They're going to look relatively flat. So you'll have to invite me back in about 10 years, and we'll see kind of what these curves look like over time. In real clinical practice, we saw this all the time. Here's lymph node metastasis I'd watched for 5 years, and for 9 years, and for 10 years. When we started watching, we just said, let's kind of watch and see if anything else grows. Let's not rush to a surgery, figuring we'll do surgery in a year or two. Now some of these guys are out like 15 years. Biopsy proven disease in the neck. So it's not only the microscopic lymph node metastasis that grows slowly, but the clinical N1 disease grows slowly as well. And this is one of the studies early on that we did. Biopsy proved only 4 out of these 22 lymph nodes grew. And when we grew, did surgery and they did perfectly fine. Now, the other piece to the puzzle then is some of these have to be growing. And we were really interested in the ones that are growing. How could I figure those out? Could we predict those? What were their growth rates? Because if you're going to watch things, you have to be under the assumption that if you treat them later, things are going to work out well. And so I wish I could tell you this is a brand new idea. Memorial Sloan Kettering is always in competition with MD Anderson, right? We always refer to each other as the #1 or #2 cancer center. This is 1956 from MD Anderson. And this is chest x-rays, because remember, 1956, this is before color TV, phones still hooked up on the wall, probably telegraphs, all that kind of stuff. These are based on chest x-rays and a whole bunch of different cancers. And see that straight line? This is a log graph of volume versus time. For the older ones of us in the room, in our original research studies, we actually used graph paper. We actually had to draw these things. So I don't want to hear any whining about research. Okay, you guys get these fancy programs to do it. And if you map the log versus time, tumors grow at a straight rate. And so we wanted to revisit that. And this is one of the early studies we did now almost 10 years ago that showed in the first 3 years, most of the papillary thyroid cancers didn't grow. That's their flat. But the ones that grew at a very predictable rate. I tell patients it's like being on cruise control. If you're growing at 20 miles an hour, it's 20 miles an hour. If you're growing at 50 miles an hour, it's 50 miles an hour. And it doesn't change. It's an intrinsic property of the tumor. And in fact, this is a lady that made me watch from 9 millimeters all the way to 14 millimeters. So again, not just the microscopic stuff. Clinically significant disease doesn't change. Now, there are a few exceptions, and it's the blue dots on that are going up right at the very end. These are 2 patients that I followed for 5 years in my clinic. They had not changed 1 iota, and then they began to grow. They were both 65-year-old guys who were minimalist and refused to let us do surgery for 3 or 4 years, which just killed my heart because I knew I was going to have to tell people that things went bad with active surveillance. And I would beg them year after year to have a surgery. And finally, their wives and I talked them into it. And these turned out to be poorly differentiated thyroid cancers. So can you pick up a new mutation and change? Yes, but it's 0.06%. So that's that same small group. And the good news is even though they made me delay therapy for 2 or 3 years, they still did great. And I'm now 5 years down the road on both of them. No distant mets, nothing whatsoever. Now, we also can find the same thing in lymph node mets. So here's the lymph node mets. We find the same thing in pulmonary mets. They're growing at that same rate. If you look at the pulmonary mets, a lot more of them are growing. If you look in the middle, about 43% are doubling between every 1 to 4 years. Those are the ones that every year you do the CT scan and they're a little bit bigger, right? That's the most common thing. You seldom see that 18% is doubling in less than a year. That's the really rapid growing. I don't think in the real world it's 18%. That's a reflection of Memorial. That's who gets sent to see us, right? For clinical trials and for aggressive stuff. And then there's a few that are decreasing, probably as a result of our therapy, maybe, right? I can't totally take the credit for that. The ones that grow fast do bad. So these are doubling times. So this is Mona Sabra's work for my group. Mona showed that if they're structural, if they were doubling in less than a year, their 5-year survival rate was closer to 50%. If you're doubling in more than 4 years, it's much higher than that. So it does make a difference. You can also use calcitonins and CEAs because that just reflects overall tumor volume. So that's the calcitonin and the thyroglobulin doubling time story that we're used to using. Those also do the same thing. If they're doubling in less than a year, it's bad. If they're doubling slower, I've got some of these curves now that run out over 20 years untreated, and they just stay on this curve year after year after year. So what it looks like is whether we're dealing with very, very small thyroid cancers, lymph nodes or distant metastasis, they have an intrinsic property that they grow at a certain rate. And they grow at that continual rate. Now, a couple of caveats. Everybody worries about the doubling time, but the doubling time of a lymph node that went from 1 millimeter to 2 millimeters does not mean they're going to die, right? I know it's a doubling time of 1 year, or a TG that goes from 0.1 to 0.2. So these doubling times in prognosis don't work on very, very small volume disease, but they do work in the setting of distant metastasis and should define how we do things. What that led then was it led the guidelines to understand that maybe early diagnosis and immediate therapy was not mandatory. And so in the guidelines, the specifics aren't important, but in terms of the nodules that we biopsy, in terms of do we have to do a surgery? When do we intervene with small lymph node metastasis? Because we were finding small lymph node metastasis that were hard for the surgeons to find, and even if they could find them, putting patients at risk for hypopara and nerve damage and scar tissue and swallowing, accessory nerve, printing, all those bad things were happening. And so began to watch, even in the setting of distant metastasis. So that led us to the final concept, which is we have to recognize that I can't unplug every ultrasound on the planet. I can't make people go back to the thyroglobulin assays we were using in 1995 that couldn't read less than 1. Although if I had an ultrasound that wasn't so good, and a thyroglobulin that couldn't read less than 1, my clinic would be so much faster because we wouldn't be talking about all this little minimal disease. And so we developed this concept that we have to talk about what's detectable versus what's actionable. We can detect stuff, but detect it and then see what the natural history is before you intervene. And how do you make that decision? You look at the size of the tumor. You can't watch a golf ball in the neck because there's not enough room up there. I can watch a golf ball in the lung if it's sitting out in the middle of the lung, not near any structures. How rapidly is it changing? What's the growth rate? We do doubling times. What's the doubling time of that tumor? What's the location? Because sometimes small tumors are in bad locations, sitting right in the TE groove near the nerve, sitting right on the thyroid membrane, sitting right on a bronchus that's going to grow. If it grew, it would get you in trouble, so you'd want to do something. And then, of course, there's that patient preference again. We see lots of people that go, no such difference between detectable and actionable. Detectable means you got to do something about it, because that's the maximalist mentality. And in the biochemical markers, we're going to use the doubling time. How high is the thyroglobulin and how rapidly is it changing to help us make decisions? So before we finish, let me come back to this. So this is where we started. So we started with your case. Lots of you guys wanted more information, so we gave you more information. Now understanding that papillary microcarcinoma is present in 10% of the population. If you're in your 60s, there's about a 5% chance this will grow over the next decade or two. If you're in your 20s, there's about a 10% chance it'll grow over the next decade or two. If it grows, we're going to be able to take it out. There's about a 1% chance you'll get a lymph node metastasis while I'm watching. And when we do, we'll do the surgery and the lymph node surgery at the same time. So now how many people would say surgery now? And how many people would say observe? Observe. Yeah, a lot of people. Yeah, so I saw one of the junior faculty at the ATA meeting this last year, and she'd been to a lot of my meetings. She'd followed our work, and she was convinced she was a minimalist. And the month before, she'd been diagnosed with a papillary microcarcinoma. And guess what she found out? She was really a maximalist. She really struggled with that. Really, really struggled. Thought she was a minimalist until it happened to her, right? So I think it opens the door, and it opens the door for this idea of de-escalation. You could paint different scenarios. I could spend an hour going through different scenarios. What if you were planning on getting pregnant in 6 months? Would you watch? Pregnancy can sometimes stimulate thyroid cancer. You could argue that you want to have your surgery done before so nothing grew. Many of my patients argue they want their entire thyroid during pregnancy. They don't want to be pregnant without a thyroid. And so they will deal with it afterwards, right? So same scenario. What if 3 of your cousins had thyroid cancer? Would you be more likely to watch, or would you be more likely to do surgery? What if you're one of my patients that we see that got radiated as a kid for their cancer and now has radiation-induced thyroid cancer? Are you more likely to watch or not watch? And what's the mom want to do, despite the fact that he's a 35-year-old guy, because mom got him through his leukemia treatment years ago, right? So you can paint different things. We ran into areas where when the Obamacare first came in, patients I've been following from 21 through 26 were having to make decisions. They were going off their parents' insurance. And if they had surgery now, it could be done at Memorial. And if they had surgery 2 days from now, they weren't sure where it was going to be done. That might change your calculus, right? Knowing where you are or where you're going. So I think all of that in addition to patient characteristics. So at the end of the day, I think whether we're dealing with thyroid cancer or whether you're dealing with renal failure or diabetes or osteoporosis, we have to understand the natural history of the disease, especially in areas like ours where there's just not a ton of randomized control trials. Prospective randomized control trials, you learn the natural history, right? That's the control group. In thyroid cancer, we have very few of those. So if you have very few of those, you really have to look at that. You have to ask, what's the data that says we're doing what we're doing? Remember, it's the Mark Twain. It's what you know for sure that just ain't so. And if you really question people, why are we doing this? What was the data that said we had to do that? What are the risks? And what are the risks of doing it now versus later? And then finally, truly understanding what the patient preferences are. This is a challenge. Because I've had to learn over the last 10 years, how do you ask those questions? I can't do, many of the patients see me now, I've seen these videos all the time, and they've watched this on YouTube. And it's not unusual for me to walk in the door and the patients say, and I say, how can I help you today? And they say, nice to meet you, Dr. Tuttle. We've seen all your videos. I'm a minimalist. Sweet. That's going to be a 10-minute visit. I am in and out of there, right? And other people go, you need to know I'm a maximalist, but my wife says I have to come talk to you about this observation, right? So they'll frequently do that. So we're working on ways to be able to sort of do some checklists or epic things to help us understand whether the patient's more of a maximalist or minimalist. If not, you can ask, what's the most important thing to you? What's the goal of surgery, or the goal of, what are you trying to accomplish? What are the things that worry you the most? I deal with a lot of professional voice users that sing on Broadway, and musicians and actors and that sort of stuff. It used to be scars. It's not anymore, because one of my last patients said, I don't worry about a scar. They do CGI and cover it over. So if you're like the lead of the movie, they don't even worry about scars anymore. They fix that. So what are those preferences that they have? And then I think at the end of the day, no matter what disease we're treating, to understand there's not really one right answer. Now, Dr. Davies points out to me, for an individual patient, there probably is one right answer for you as an individual person. But for me, as presenting options to you, I give you the option of 1 or 2 right answers and get out of the concept of right and wrong. Patients struggle with right and wrong. You never want to be wrong in cancer, right? You don't want to be wrong in acute MI. You don't want to be wrong in bad tumors. You don't want, right? That right and wrong, we all don't think about it as 2 right answers. And so years ago, I stumbled across this statement of, we're going to choose between 2 right answers. And then you see patients just relax. Say, okay, if there's 2 right answers, let's explore what's the right one for you, and then we'll sort of go from there, realizing that it is a range of options, and that as a group, many times we do want to maintain the status quo, but when the landscape that we're treating, when the stage of disease, early staging, whether it's hyperparathyroidism, whether it's early lipid, whether it's early diagnosis of a glucose intolerance, or whether it's small thyroid cancer, early recurrences. When we start applying our one size fits all to a landscape that's changing, we should all sort of ring a bell and say, now wait, is this something we need to do? Not automatically escalate, but ask the question, is it necessary to escalate? And if you're doing just enough, when you start seeing those low ones, you'll automatically be asking what's just enough. But if you're doing one size fits all, overtreat everybody, you're not going to ask it, and it's going to look better and better and better. Thanks very much. Perfect. Okay. So there's probably questions from the audience, and there's probably questions online that I can't see. Yes.
Great. Just want to say thank you, Dr. Tuttle. Really appreciate your approach, and it's going to, I think, pervade a lot of other specialties that'll have to stop and rethink the way things are done. So I'll turn it over to Dr. Mashgundam.
Oh, perfect. Yeah, I appreciate that. I think that's why I give this talk for a general medicine audience, because I don't know how that resonates in the various diseases you see, but this is a common thing about how we decide, and especially these days with truly shared decision making. Patients want to know, how confident you are that's the right thing. I will tell patients, if I think you're making a wrong decision, I'll tell you. If I think you're doing something wrong, now, you're an adult and you can do what you want to do, but you will know. And I will tell you, my note says my preference was a total thyroidectomy. But we talked about it, and based on their preferences, she wants me to follow with observation, and I'm willing to do that, understanding the risk and benefits, as opposed to do what I say or go see somebody else. That's a hard thing. I know it's easy for me because I work in a cancer center and we have phenomenal lawyers, but the reality is, helping people understand that. Yes.
So the last part of the talk where you talked about, the growth rate and all that. So is that becoming like a AI in the era of AI now? Can we plug in those data and have a
Yeah,
because we don't have the kind of time that you talked about. So when we're seeing a patient in the clinic.
Well, that's exactly right. So the volume stuff automatically comes off ultrasound machines.
Mm-hmm.
They just don't report it, right? They'll give you the 3 dimensions, but it's automatically calculating volume. So you can have the radiologist just give you that volume thing to put on. I use an Excel spreadsheet from Kuma Hospital. We're going to try to build that into Epic.
Mm-hmm.
And we're going to apply that to lung metastasis and cervical lymph node metastasis, because it turns out we're not so good at doing volume with our heads, because a 1 millimeter nodule that goes to 2 millimeters to 3 millimeters is not linear growing, right? Volume is radius cubed. So we really have to think about it as 3-dimensional volume. So yes, we're going to Epic this year, which is like phenomenal pain in the tail. But part of that, we're trying to figure out how do we get this. Because our oncologists are interested in this as well, because if you have somebody that's growing on their lung metastasis, right, and you put them on a kinase inhibitor, they'll shrink, and then they'll stay stable for a while, and then they'll start growing again. Now, if they were growing with a doubling time of 1 year, and now when they stop working, they're regrowing with a doubling time of 5 years, should you stop the drug? I would say no, the drug is still working. If they go back to that 1 year doubling time, your drug has failed. So we're sort of thinking through what does it mean for oncology trials and medicines for that.
Dr. Tuttle?
Yes.
I joined a little bit late, but I don't know if you've already said this, but how do you handle people who grew up in Chicago and were irradiated because they had large tonsils?
Yes. Yeah. So that's the home. Chicago was the home of really understanding in the sort of 1960s, 1970s that radiation during childhood caused thyroid cancer years later. If you go back to the textbooks in the 1950s and you look at radiation resistant organs, guess what we knew? We knew it was the thyroid. Radiation never bothered the thyroid. So it took about 15 years for people to be able to understand that. And it was Art Schneider in the group there at Michael Reese that made the heroic decision to actually call patients back that they had treated with radiation 10, 15, 20 years ago and screen them. Could you imagine an organization doing that now? Hey, we might have caused thyroid cancer, come back and see us. That was a big deal back then. So if you have a radiated gland, the likelihood of the nodule being thyroid cancer is about 30%. So they often end up being treated. Now, but we see some of those folks that are 20, 30, 40 years down the road. And as long as they're willing to follow with me, I actually follow with them as well. because I think if they haven't changed that much by then, if they change, we'll do it. We also tend to do a total thyroidectomy on them because the whole thyroid had been radiated, but even I'll break that rule if they're in their 60s or 70s. So that does frame in, to my mind, almost like a real family history of 4 or 5 different family members. Yep.
So for these low risk lesions, how often and how long would you recommend?
So for the folks that we follow with active surveillance, we do, yeah, get out of here if you need time. It's time to go to work. For the low risk patients, we follow with ultrasounds every 6 months for 2 years, not because they're rapidly growing, but I need to know what their doubling time is. So 4 ultrasounds over 2 years will tell me what it is. If it's nice and stable or slow, then we do it once a year through the 5-year point. After 5-year point, I do it every 2 or 3 years. After 10 years, I'm begging them to come back and see me for my research because honestly, I'm more worried about their thyroid cancer than they are at that point. So it stretches out over time. Right now, we're following everybody forever, but we need to stop that at some point. When I started active surveillance years ago, Drew Ridge, who's a surgeon at Fox Chase, Drew told me he would support my active surveillance program if I promised him I would develop an inactive surveillance program 10 or 20 years down the road. So I think some of these guys, we're just going to have to say, you're not going to change, get out of the system.
One more question, and that's related to the GLP-1
Mhm.
sort of the era. So, and also in summer is where we have the state fair, and after that, with all the, little ultrasound machine in the state fair, the patients fall back with this little thing saying, hey, now I have it. So I've had some consults asking for, there's a nodule, we want the patient on a GLP-1, do they need biopsy? So, your thoughts and comments on that. And
Yeah.
there's no family history, nothing like that. So
Yeah. So as a group, we don't think GLP-1 really causes medullary cancer. So that's my bias. I know it does in mice, and I know it does in rats. But there is essentially no data. There was one horrible paper from Europe that I'm aware of that's now been disavowed. But there's no real data that this causes anything in adults. So we don't recommend screening before you put somebody on GLP-1. If they have a nodule, if we weren't going to biopsy anyway, we don't biopsy it. We figure if we're wrong, one of these years, something will grow and we'll be able to fix it. So no, we don't recommend screening with calcitonin because you just get too many false positives with Hashimoto's thyroiditis. But we still see that because it's a common thing that happens. So our group just sort of says, no, we don't do screening as long as there's nothing else about that nodule. If it looks benign, I don't do it to prove that there's something there. And it's just really common out in the private practice because of black box warning. For the ATA, I've been running a medullary thyroid cancer registry for the last 15 years. All the companies have to agree to 15 years post-marketing surveillance. And so we're doing that. And so with every company, with every drug, we get to see the data every year. And there is just no signal that we can see that medullary is going up in patients that we're not. So we're in the process of trying to begin to talk to the FDA about getting that black box warning off. If you think it's hard to de-escalate in clinical practice, good luck de-escalating with the FDA, right? So we're looking at ways to do other studies to be able to get that black box warning off. Yes.
A couple of questions from our chat area.
Sure.
on Zoom. One is from Dr. Engel. He's one of our community doctors.
Sure.
Who participates. Says when patients with neck nodules go to the FNA clinic, do endocrinologists do the US guided FNAs? What is the rate of equivocal FNA diagnosis of the pathologist versus the radiologist? What percentage of patients do not opt for watchful waiting in your shared decision-making conference?
That's a great question. So we'll do it backwards. So both in the Japanese center that started this and ours, about half of the patients will accept active surveillance. It's about 50%, and it's minimalist versus maximalist. So it's about 50%. For the thyroid nodules, as long as the ultrasound the person's doing ultrasound guided biopsy, the results are about the same. If you're in New York, there are community centers where you can go get the biopsy. They look exactly like what we do at our place. It's just they know how to do it, and it's a repetition. So yes, we see about the same thing. If you're not doing very many of these, it's like anything else, you'll get more insufficient rates. It also depends on whether you have on-site quick reads. All of those places, like if it's done in pathology, they'll do a quick look with a diff quick to make sure you have adequacy. In the old days, we did it without that adequacy, and you would not have enough biopsy. So as long as you're having some quick on-site that shows you've got in the nodule, you've got adequate cells and ultrasound, it pretty much looks the same.
Another question from Dr. Philip May. He's one of our our friends here in the community doctor who attends a lot must know, for those patients who you decide to only observe / monitor, do you recommend any lifestyle changes?
Oh, that's a great question. So these patients at the end of every visit, once they've decided to watch, the last question is always, tell me what I can do. Is there anything that I can do? And so I tell them, I don't know, because I don't know that anything does or bad. I also tell them that because I grew up in Kentucky, I recommend bourbon. And that always gets a laugh and generally gets me a bottle of bourbon for Christmas every year. So my patients know that that's my joke that I tell them. So nothing that we know to do or not do. But I will tell you, probably 80% of my folks that are watching are self-treating themselves. They've changed their diet, they changed their activity, they try to improve their immune system. So there's a lot of stuff going out. I tell them they're the worst research patients on the planet. They do 25 things at one time, and I'm supposed to figure out what worked. But apparently they're not willing to do one thing for a year, and then one thing for a year, and one thing for a year. So right now, I just honest with them, tell them I don't know, but nothing that I can tell them to do or avoid that makes any difference.
And the last question is actually from Dr. Stephen Winters, our former division chief at
Sure.
endocrinology, said it is very difficult and subjective to read nodule characteristics in the US. Are there AI programs to analyze US in development?
Yeah, that's a great question, Steve. Good to see you. Thanks, buddy. Yes, there absolutely are. There's several studies now that show if you're a relatively new ultrasonographer, that adding AI helps you. If you're a very experienced ultrasonography, AI doesn't add that much. So there may be something either in the learning curve or those pieces to it. But yes, radiology is probably 5 years ahead of everybody else in terms of, because they've been doing pattern recognition forever. So that it lends itself to the AI. So yes, I think we're going to see that. But all the studies thus far have shown that AI by itself is not as good as the radiographer yet, although it's continually learning. So yes, I think, and then what I hope is that the radiology output gives us sort of the same thing that Bethesda does, right? For cytology, Bethesda 1, 2, 3, 4. We need a standardized terminology that ties to risk of malignancy, and whether that's TIRADS or the ATA system, that I hope the output of that AI is some classification that we go, okay, that's 5% risk of cancer, 10 or 20. So yeah, Steve, definitely moving in that direction.
That's all from the chat.
Awesome. Fantastic. Thank you very much. Thanks for everybody online. Appreciate it.
Before you go,
Uh-oh.
I know Dr. Wood would typically do this presentation, but we have a little gift for you as the Beverly Todd Towery lecturer. Obviously, this is from Kentucky.
Oh, my God.
Little, you'd be familiar with something like that.
Absolutely. Holy cow.
And it's inscribed, Dr. Tuttle, this year's Beverly Todd Towery lecturer, University of Louisville, February 29th, 2024.
Jason, I will tell you, I've had the good fortune to travel the world and have received gifts from everywhere. This is going to have to be hung up high to keep my grandkids, who are baseball players, from getting their hands on it. My wife will absolutely allow me to hang this in the house, as opposed to most of the stuff I bring home. Very special. Thank you very much. I really
Thank you,
appreciate
Dr.
that.
Moksha-Gundam and Dr. Williams to the the endocrinology division, and Dr. Williams chair here. We it's just a little token, and we appreciate you coming home to speak to us. We appreciate
Absolutely.
it.
Oh, that's so amazing.
Thank you.
My grandkids are
Speak
gonna love
for the
that.
Yankees.
Yeah, they're Mets fans. I don't know. So,
That's right.
oh, that is so cool.
Thanks, Dr. Tuttle. And
Oh, thank you so much. I appreciate it.
Absolutely. So, Dr. Moksha-Gundam will handle the Cardinal Minute, and
Yeah.
we'll sign off.